Hi, everybody. I'm Aakriti Gupta. I'm one of the associate editors at JACC and also a structural interventional cardiologist at Cedars-Sinai. I'm very honored to have Dr. Michael Reardon today, who is the professor of cardiothoracic surgery at Houston Methodist and principal investigator of the Evolut low-risk trials. We are here to discuss one of his recent publications in JACC, which is also late-breaking at CRT, where they pooled a lot of data for intermediate and low-risk patients for the Evolut trials and registries and tried to understand the association of bioprosthetic valve dysfunction with clinical outcomes. But with that, I will give the floor to Dr. Michael Reardon. And how about you give us a little bit of overview on what inspired you to do this study and what are some of the primary take-home messages?
Aakriti, thank you, first of all, for having me on and talking about this study. The study's been very important to us. As a surgeon, I've been watching the advance of TAVR. And of course, TAVR has become the dominant treatment for severe aortic stenosis in the U.S., regardless of risk. And we're moving to younger and younger patients. So durability and valve performance becomes really, really important for us. And we originally did a paper just on structural valve deterioration, but then I went back with Steve Yakubov and we looked at overall valve performance to include structural valve deterioration, non-structural valve deterioration, endocarditis, and thrombosis. And this study was to look at all that using the extreme and high risk and intermediate risk population. We took the randomized arms from high risk and intermediate, and we looked at these randomized arms to look at the actual incidence of valve performance, the structural valve deterioration, non-structural thrombosis, endocarditis. And then we added in the non-randomized arms of the high risk, extreme risk, and intermediate risk. And we used that larger number to then look for associations for clinical outcomes for those that did have this. So that's kind of the study in a nutshell.
Great. So one of the things that came to mind that your study emphasizes better quote unquote valve performance with the CoreValve Evolut TAVR arm compared to surgery. And as a surgeon, I would ask how might these results influence the debate between TAVR versus surgery in intermediate surgical risk patients? Because like you said, I think the default has the Overton window has already sort of moved to TAVR. So are the results of your study sort of validating that? And I know I'm being a little provocative, but I just want to hear from a surgeon.
No, Aakriti, I mean, I agree with you. And certainly, when I think about this, one of the things I try to think about is how much time do these people have left on Earth? How long are they going to live? Mm-hmm. And if you look at the data from the Sweetheart registry, which Sweetheart, everybody in Sweden has their surgery recorded. And by law, all the deaths are reported, so they get 100% follow-up. And so they looked at their group of folks and they divided them into high, intermediate, low risk, and then they divide them up to 5-year groups. And in the high risk, intermediate risk, only intermediate risk made it at one little point up to 10-year mean survival. I've had more than a 10-year survival. So what I'm thinking is, do we have a valve that has 10-year durability for most of these folks? And I think one of the things that we're starting to see is that if you start with a bigger EOA, you do better. We know that from surgery. The bigger surgical valve I put in, these pericardial valves fail by stenosis, the longer they tend to last. So this has already influenced the field of surgery, and the number of annular enlargements that we're seeing has gone way up. I do it in about 40% of my cases. I have a rule that women never leave with less than a 23, men less than a 25. And so this kind of data is already making the field of surgery more attentive to those that we do operate on. How do we do a proper operation?
So I think you brought about a very important point, the point for annular enlargement. And one of the notable findings in the study was higher incidence of severe patient prosthesis mismatch in patients receiving surgery compared to TAVI. And you mentioned you do annular enlargement in 40% of your patients, but that is definitely not the routine practice, at least in the US. So can you speak a little bit to that? How frequently are surgeons doing annular enlargement, and what are the efforts to really drill that down? That is something very important to consider. And maybe annular size has to be something that is rigorously considered when we make these choices. For example, in my practice, if I see a patient patient whose annulus is, 270 or 260, we always talk about, the TAVR valve is going to be undersized, but sometimes what drives us to doing the TAVR is, well, the surgeons are going to put in a small 19 valve, and maybe we can actually do either an undersized 23 Sapien or a 20 or an Evolut. So how do you think about all of that, and what are the steps in this direction?
Yeah. So I often get asked by cardiologists, if I have somebody that's reasonably low risk, they could have surgery or TAVR, what should I do? And first thing I tell them is, well, tell me about your surgeon. What valves do they send back to you? If they're sending back 1921s, either do a TAVR or, more importantly, get a surgeon. Now, in the low-risk trials, the number of annular enlargements was about 5% or less, but things have changed since the trial. We had, before than just a Nixon-Manugian posterior enlargement, which usually lets you go up one size, and sometimes two. We now have the Bo-Yang Y annuloplasty, always lets me go up two, usually three, and sometimes four sizes. So now I get a CT on everybody I'm going to operate on. I get an area-derived diameter, and I try to pick a valve that has an inner diameter that matches that. So TAVR has made us better. But on the TAVR side, I think we're seeing some really encouraging data for the self-expanding valves, particularly these early generation valves, that show that we have less structural valve deterioration in surgery. We have less patient prosthetic mismatch. And that to me, the inverse of valve dysfunction is valve performance. So we're seeing a better performance. Now, I'm hoping surgeons can catch up to some extent. But as you know, really, our TAVR valves continue to get better as we engineer them. And there's no question in my mind that the kind of the revolution of TAVR is going to continue with more incremental improvements. At the same time, this is making me as a surgeon rethink what I do. For those that I do operate on, I look at them and I ask, what can I put in now? And if this fails, and it goes back to Dr. Gupta, how likely is she going to be able to put a TAVR in this? And if you're not planning for the future as a surgeon, you're doing the wrong thing.
That's a great perspective. And I think, as we all know, we're talking more and more about the importance of lifetime management and, the index sequencing of therapy. So it really matters. What is the first valve you put in? Is that a surgical or a TAVR valve? And if it is a TAVR valve, is it a self-expanding or a balloon expandable valve? And there's so many nuances, even in the procedural technique in those valves. For example, I remember when I started training balloon expandable valves, we were encouraged to put it as high as we can so that we don't induce conduction system disturbances. But now it's more like, 80-20 because we want to be below the coronary takeoff so that, when we have to do valve and valve, we're not threatening the coronary. So I understand you are PI of one of the biggest self-expanding valve companies, but how do you think about your choices as the index valve about balloon and self-expanding? And I understand the hemodynamic aspect obviously is much better when we talk about self-expanding, and we saw in the SMART trial, particularly for small annuli. But one of the things I am often thinking about when making these decisions is that it's not just about hemodynamics, because firstly, I don't know if we've definitively shown that they're translating into differences in long-term outcomes, but how about all the thoughts about, when we have to go valve and valve, the supraannular leaflets will be a problem for the coronaries, higher pacemaker may be a problem. So how do you think about all of that?
Well, a couple of things. First of all, we've looked at pacemakers, and the people that have the worst mortality are those that come in with a pacemaker, because a pacemaker is an indication of disease. And if you get a new pacemaker when you're pacemaker naive versus not getting one, there's no real difference as we follow that long term. But still, I'd rather not have a pacemaker. No question, having a pacemaker is not a good thing to do. And yes, you should be thinking about, valve and valve. You should be thinking about coronary access. All those things are important. Obviously, with the Evolut FX Plus and with commissure alignment, coronary access is really not an issue for us anymore with the self-expanding valve. But again, whether or not we've proven patient prosthetic mismatch in TAVR makes a difference, we will. We had this argument for many years in surgery. And once we got enough data, it's really clear. We know from George's echo data in Australia that any level of AS decreases your life expectancy. And so, we'd like to increase the hemodynamics of our balloon expandable, also. I think it's more important for me, because the first cut is the deepest, is to try to pick the best valve and think about the future. Now, there are people that I can look at that have fairly low coronaries, fairly small sinuses, and if I put in a self-expanding valve, I may not be able to do a valve and valve, and I pick a balloon expandable valve, and which I do a lot of. I mean, we think they're very good valves also, or I may have somebody that has big sinuses, high coronaries, but small annulus, and I say, fine, I'm going to put a self-expanding. If that fails, it's going to be a very good setup for me to put a balloon expandable valve in there. But if you use this every day, it's hard to say use this or that without seeing the patient, how long you think they're going to live, how active they're going to be. A 70-year-old that still tries to bike and run every day is different to me than an 84-year-old that's going to sit on the sofa all day long. And so these are complex things. I think in 80% of the cases, it probably doesn't matter. I was not part of the SMART trial only because I didn't think there was equipoise in using a 20S3 because Becky Hahn showed us that the EOA was 1.22. Get to 23, I'm okay. But in the trial, I might have been forced to put in a 20, so my team wouldn't randomize in the trial. So I do tend to use self-expanding in smaller annuluses. I tend to use them in valve and valve, but again, I do balloon expandable every day. A 29 in a man, a 26 in a woman. They're probably going to do fine. Now, I will say that if you look at the P2 data that was presented, the XT, of course, the randomized arm did worse than surgery for valve performance. The S3, the non-randomized propensity matched arm, numerically was higher, but no statistical significance. But if you go back into the very end of the supplement, what you see if you do a inverse propensity treatment weighting, which gives you a little bit better pseudopopulation, actually S3 had more valve failure at year 4 and 5. So those are worrisome things. That being said, there's now new generations of that valve too.
Correct.
I think we're going to continue to engineer our way, but I think it's important for us as a field to consider overall valve performance, structural, non-structural, and hemodynamic thrombosis. It seems to be a wash. Certainly in the self-expanding, there's no difference.
And I think that's a great way to segue to the fact that, the iterations in technology are really what is so fascinating and what makes us want to do this every day. Because literally you start a trial with one thing and 5 years later, when you're done, there's so many other generations already that the data is already obsolete in some ways. So I think this was very, very educational. And thank you so much for sparing time for this. And good luck for not only your CRT late breaker, but I know you're also presenting the 5-year low risk at ACC. Yeah. So there's a lot of very good information coming our way in terms of TAVR versus surgery. And let us know if you have any final thoughts about what is the next big question that, how about this? I actually asked this to everybody I interview. If you had a time capsule and you had to predict what we will be talking about 10 years from now in our field, what would that be in the context of TAVR versus surgery?
Well, I think TAVRs can continue to take over more of the field of surgery. That being said, my actual isolated aortic valve surgery has gone up since 2020 because I have more foot traffic through my valve clinic wanting a TAVR valve, and they're just not appropriate for TAVR valves. Again, Notion 3 showed us that for bicuspid valves, the hazard ratio was about 3.4 versus surgery. Now, it didn't reach statistical significance, but that
it was quite underpowered, but yeah.
It underpowered, but it begs for a randomized trial, which I know your partner, Dr. McCarr, has pushed very, very hard for. I think we're living in exciting times. We're going to continue to talk about, how we improve on these valves. We still need to do work with cerebral embolic protection. We haven't gotten where we need to go. And of course, as you know, we have the mitral and tricuspid coming up, and those are very exciting fields. So again, I wish I was younger. I'd like to do this for 20 more years. This remains exciting every single day. This data, I think, adds to the confidence we have in our TAVR valves if we're going to be putting them in people that are younger and lower risk.
I think that's a great way to sum that up. Thank you so much, Dr. Reardon.